It's my pleasure to introduce Dr. Schechter. His CV is long and impressive, so I'm just going to hit the highlights that are most relevant to his current position. He is an associate professor of pediatrics in the division of pulmonary allergy, cystic fibrosis, and sleep at Emory University School of Medicine, and is also an associate professor of environmental health. He is currently the director of the Emory University Cystic Fibrosis Center, associate chief division of pulmonary allergy, cystic fibrosis, and sleep, and the medical director of Children's Healthcare of Atlanta Cystic Fibrosis Program. We were very lucky to have Dr. Schechter join us from Brown University in 2006 as CF newborn screening was getting off the ground. The CF newborn screening is something that Dr. Schechter had extensive experience with in Rhode Island, and coming into Georgia that experience was very valuable to the program, and at the time as we were getting started and going forward as well. So I'm not going to spend a lot more time. I want to give you as much time as possible to tell us about cystic fibrosis newborn screening.
Yeah, thanks a lot. And thanks for all having me come. I actually had no experience in Rhode Island. We were setting
heard
it
that
up.
you had.
Well, we were setting it up in Rhode Island around the same time that you were setting it up in Georgia, but we had a little bit of a head start because we were working along with the Massachusetts group, and so there was a lot of interaction based on their experience.
Well, you knew more than we did.
So anyway, so we've been doing newborn screening now nationally for the last 5 years, the majority of states, and so it's interesting to talk about what we've accomplished, what we intended to accomplish, and what we actually, and some of the things that we have. So just a couple of introductory slides. CF is the most common life-shortening genetic disease in Caucasians. Affects about 30,000 people in the U.S., around 60,000 worldwide. Here are the demographics by race, ethnicity, or so on. Here's the answer to your first question. As far as 1,000 new cases a year in the U.S., approximately. About 44, actually between 30 and 40 when you come down to it, between 30 and 40 new cases a year in Georgia. CF is an autosomal recessive disease caused by an abnormal gene on the long arm of chromosome 7. The gene product is called cystic fibrosis transmembrane conductance regulator. The cartoon looks a little bit like this, which locates in the apical cell membrane and which functions as a chloride channel and also helps to regulate or is the primary regulator of the epithelial sodium channel. In order to understand CF pathogenesis, you need to understand that under normal circumstances, the airway surface looks something like this. We have ciliated epithelial cells. These cilia kind of move in a synchronous manner and are kept happy by the presence of a very thin airway surface liquid layer here. And then on top of that airway surface liquid layer is a mucus layer. And the level of this airway surface liquid layer is actually determined by ion transport, sodium chloride secretion, sodium reabsorption, and that's the role that CFTR plays. So under normal circumstances, this is an electron micrograph that shows, again, cilia in their water and the mucus on the surface. And so these are happy cilia, and then these are the happy and overcrowded cilia in CF, where they're missing this this layer. So basically then what happens is that, I don't have other slides that can show up, but this slide sort of gives a summary of this whole pathogenesis that begins with mutant CFTR leading to depletion of this periciliary liquid or airway surface liquid, which then in turn causes defective mucociliary clearance of bacteria that are inhaled. And the result of that is this sort of cycle of infection causing inflammation and inflammation and swelling that ensues with the inflammation causing obstruction. Inflammation, incidentally, is magnified in CF, and the mechanism of that is not entirely clear. But so you end up with this cycle that becomes kind of a downward spiral of ongoing obstruction, infection, inflammation, leading eventually to progressive and irreversible lung disease. So that's the CF story. And this is what we end up with. This is an explanted lung, somebody getting a transplant. You can see all these holes here are what we call bronchiectasis. This is what it looks like on the CT scan. So just to give you an idea of what's been going on in the last decade or two with CF, this is data, and I'll be showing you several slides from the Cystic Fibrosis Foundation registry. This is a description of median predicted survival over the last 25 years or so in these 5-year bands, and you can see that there's been a progressive improvement in the median expected age of death, so it's around 38 at this point. At the same time, and you can think of this as being lung function amongst the survivors. This is cross-sectional data in 1990 in red, in 2009 in blue, with the x-axis showing age, the y-axis showing our best measure of lung function, which is FEV1, forced expiratory volume in 1 second. And we talk about it as percent predicted, so it's sort of adjusted for size and age and so on and so forth. So you can see that basically, and so 100% is basically what you'd expect somebody who's completely healthy and normal to have. And so you can see actually that the percent predicted FEV1 these days really doesn't start dropping below 80, which is generally what we consider to start looking at normal until kids are 18 or so on average. So we've been doing a pretty good job in preserving lung function. So what's the reason for that, or how did we do that? Well, we can talk about various innovations in terms of medication and therapeutic approaches that have been introduced, but the fact is that the most important and most effective way that we've made these changes has been through really learning how to use the tools that we've already had available to us. And using those tools in an anticipatory manner and maintaining high expectations, being aggressive and proactive in our treatment, and the use of the drugs such as antibiotics, nutrition, and so on and so forth. And this is where newborn, and the reason why I'm going through this is because this is really where newborn screening fits in. So the history of newborn screening for cystic fibrosis really begins, the first place that it started was 1979 in New Zealand, and soon after Australia. In this country, Colorado started doing newborn screening in the early 80s, and then Phil Farrell and his group in Wisconsin actually got funded through NIH to do a double-blind controlled study of newborn screening, where they literally did, while they screened everybody, they didn't actually open and let anybody know the results of that screening in half the patients. And so certainly couldn't do that anymore right now, but back then when it was really unclear about what the potential value would be, that was, that could ethically be done. So they were able to show in a fairly convincing, conventional way the advantages of newborn screening. In 1997, the CDC and CF Foundation sponsored a joint workshop, and at that time, they felt that the evidence was unconvincing to recommend newborn screening. But with additional data over the next several years, in 2003, another joint conference was convened, and at that point, and this was published in MWR in 2004, the determination is made on the basis of preponderance of evidence that health benefits to children with CF outweigh the risk of harm and justify screening for CF. And so following that determination and that announcement was really when sorry, I thought I had a different slide here. It was really when the various states around the country began to pick it up. Really, at this time, there were probably 4 states in the country that were doing newborn screening. It was Wisconsin and Colorado and Massachusetts, and there was a little bit that was being done elsewhere in Pennsylvania and in Connecticut, but nobody else really. But at this point is when the various states started picking it up, and so that's why, again, Georgia started planning it through 2006, I guess, and January 2007 when it began. And so just to give you an idea about what kind of impact that's made in terms of diagnosis, if we go back to 2006, again, this is data from the Cystic Fibrosis Foundation registry, and this shows you on this graph here the age at which patients were diagnosed with CF. And you can see that basically about half of the patients were diagnosed in the first 6 months, and then the other half were diagnosed throughout childhood and even into adulthood. So that because of that rightward skew, you had the mean age of diagnosis of about 3. And the diagnosis was suggested by these symptoms. Again, roughly half of the patients did have respiratory symptoms at birth. About 2/5 had failure to thrive or malnutrition. About 1/3 had abnormal stools. 1/5 had meconium ileus, which is a neonatal bowel obstruction, which usually requires surgery. Family history only, again, sort of being a close relative that led to specifically testing the patient in only about 1/6, and newborn screening at that time was a really small minority of patients. In contrast, this is from the 2009 CF registry, and you can see this is the percentage of patients who are being diagnosed, or percentage of new diagnoses by newborn screening, and you can see that there's this really dramatic upward spiral, and so really we can expect that the vast majority of patients from now on are going to be diagnosed. There's still obviously going to be a backlog of patients who were not ever screened, and then we also, frankly, I think I'm going to show you a couple of slides here. Our newborn screening is not intended to be 100% sensitive. It's too hard to do that, or too expensive to do that. So there's always going to be an occasional miss as well. So clinicians need to be aware of that. So how do we do newborn screening? So this is the answer to one of your next questions. But so immunoreactive trypsinogen is the starting point in newborn screening, and the way everybody does it, both in this country and internationally. IRT is a pancreas-derived enzyme typically elevated in all patients with CF, interestingly, including pancreatic sufficient patients. So there's a little bit of a hit that the pancreas takes even in patients who have normal pancreatic function. It's not, it does have some variation according to patient. Patients with meconium ileus are more likely to not have elevated IRT. Infants who are low birth weight or have had some perinatal stress are more likely to have elevated IRTs. African Americans, and I'm going to show you some slides from what we have in Georgia. African Americans tend to have higher IRTs than Caucasians, and overall the sensitivity and specificity of this initial first step, and this is always going to be the first step in newborn screening, is going to depend upon cutoffs, and there are different approaches to those cutoffs, both in terms of of absolute versus a floating cutoff on percentile, and then also decisions being made about what your acceptable sensitivity and specificity are going to be. So this is the status as of 2009. Again, what we used to do over the last 5 years is we would show a map with different states that are actually doing newborn screening versus that don't do newborn screening. Texas was actually the last state that joined the union, but at this point, all these states are doing it, and there are broadly speaking, there are 3 different techniques that are being used, and I'm going to spend a few minutes talking about. So the red states are IRT DNA. In other words, they start with IRT, and then their second level of screen is looking at a mutation panel. There's IRT, in which the states do an initial screen for IRT, and then in about 14 days, they look again, and so patients who are positive have 2 IRTs, and then IRT DNA is a modification on IRT that is just beginning to be adopted by a number of states. And here, what it is basically patients in whom there are 2 elevated IRTs will then get a DNA panel. So to do the IRT, and again, this was the first. This is what Colorado was. Again, given the fact that Colorado was the first state that started doing newborn screening, this is kind of the original approach, at least in this country. So IRT is assayed in blood specimens collected in 1 to 2 days, and again at 14 days, 2 elevated IRTs constitute a positive newborn screening. And then basically, again, what you'll see here, the pattern for those of you who don't know this, is that newborn screening for CF has built in a very high number of false positives. Okay, so basically a positive newborn screen doesn't mean you have CF. A positive newborn screen means that you need to get a sweat test in order to confirm whether you have CF. And again, depending upon how it's being done and who's doing it, what we really are talking about is somewhere in the range of 10 to 20% of people of kids who have a positive newborn screen will actually have CF when you do the sweat test. So again, here looking at the Colorado data, actually that was published in 2005, using their cutoffs, which was 105 fixed. Of those infants with positive first IRT, only 3% have CF, and of those with 2 elevated IRTs, about 16% had CF. And at least in Colorado, their sensitivity was about 95%, although others have analyzed their data and suggested that their sensitivity is less than that, meaning there's more missed cases. So the IRT DNA, which is what we use here in Georgia, IRT is assayed in the blood specimens collected at 1 to 2 days of age. If the IRT level on the initial blood spot is elevated, that same blood spot is then tested for CFTR mutations from a predefined panel. Now here in Georgia, right now, what we're using is 55 as a fixed cutoff for our IRT threshold. And then we had been using a larger panel, but we're currently using a panel of 23 mutations. So again, the point here is, since there are nearly 2,000 or maybe even over 2,000 CFTR mutations that have been described, the idea is that we're not going to be able to find all of them. So if you have an elevated IRT and even 1 mutation, then that infant is considered to be a positive screen and is referred for a sweat test. And in general, the sensitivity of this approach is 96 to 98%. Positive predictive value about 3 to 10%, again, depending upon various cutoffs. So just to give you an idea here about IRT DNA and what these different approaches are, just to give you a sense of this. Fortunately, you didn't get tested on these numbers. But again, so Wisconsin, for example, uses all of these states are using floating cutoffs. In other words, they're looking at whether the top 4 or 5% in any given day or at any given week, depending upon how they're doing it. So again, Wisconsin uses the 4th percentile, Massachusetts and New York uses the 5th percentile. Some of the states use a very high so-called fail-safe. In other words, if your IRT is in the top 0.2 percentile, even if you've got a negative, even if you don't have any mutations discovered, those patients are referred for sweat testing. These are gradually being discarded because they tend to not really add very much to the overall diagnostic sensitivity. And then the other thing I'll just mention is, again, sensitivity 96, 97.5, 98, positive predictive value. So sensitivity, I'll show you, sort of gets higher down the list, and the positive predictive value gets lower. And some of this is related to their choice of cutoffs, and frankly, some of this is related to the proportion of different races and ethnicity. So Wisconsin, is really, doesn't have a lot of Hispanics or African Americans, and so the positive predictive value, their positive screen is much higher. In New York, where there's a lot more African Americans, positive predictive value for the whole population is a lot less. So we'll talk about this a little bit more a little bit later on. So the pros and cons for IRT and the IRT DNA, IRT, the main issue about that is it requires collection of a repeat specimen. And in some states that's been set up pretty well, but in other states that would really be a problem. And that's probably the hardest part. If you don't get that second specimen, then the whole screening system falls apart. So the idea about loss to follow-up is really a potential problem. And then again, even if it's collected, there does seem to be some evidence that the sensitivity for IRT is somewhat lower than IRT DNA. The problem with IRT DNA is that now we're beginning to find a whole bunch of carriers, and that adds the burden of extra knowledge, meaning that ideally these patients should get some sort of genetic counseling. And unfortunately, and frankly, Georgia is as good an example of this as many other states, the genetic counseling part of it doesn't really get done and funded as well as the recommendations, at least by the CDC panel, work. And again, whether they like it or not, we're letting people know about whether they're carriers. And again, that's not really the bottom line reason for doing the screening. So this is extra knowledge that we don't necessarily need. So this is one issue that gets into, again, what we'll be talking about a little bit later about CRMS. So California, of course, is an exception to what everybody else does. They came up with they've got this guy, Marty Karazi, who's at their Department of Public Health, is very, very involved with newborn screening and shows up actually a lot of the CF meetings and is really very, very knowledgeable and involved. But anyway, what they do in California, they start again with IRT, but what they do is if the IRT is elevated, and they use a relatively high cutoff, this is 98.5 percentile, that same blood spot is then tested for the mutations from a predefined panel, so that's similar to the IRT DNA. But then those who find, for whom there's one mutation found, they go ahead and do sequencing rather than getting involved with sweat testing. And doing this approach, their sensitivity is relatively lower, but the reason for their sensitivity being relatively lower is not about the overall approach, it's about using this IRT at this high cutoff. But they accept that as 93%, and then their positive predictive value is much higher. And then there's this IRT DNA that I mentioned too, that the people actually in Colorado have recently come up with and are promulgating. And what they do here is their initial IRT has a lower cutoff than what they're currently using. So that increases the sensitivity. And what they do, again, they do their second IRT, and then if that second IRT is elevated, then they put the blood through a 43 mutation screen, and their mutation screen is specifically tailored to their population in Colorado that apparently has a fairly high preponderance of Mexicans and other Hispanics, and so they have a screen that's weighted towards mutations that are found in that population. And so then again, patients with one mutation, or this is sort of their version of the very high fail-safe, are referred for sweat tests. So their estimates, this hasn't been used for that long, but based on what they've already been doing, they estimate that their sensitivity would be very, very high using this approach. they would be getting far fewer carriers than just the plain IRT DNA. In other words, a better positive predictive value, and that overall this approach would be less expensive. Again, it's very appealing, but the problem here is needing to get these patients for that second return, and that's a challenge. So I want to talk again, since IRT is, as we talked about, is really the starting point. It's important to really look at what IRT does and what it doesn't do, and where the problems are. So the biggest problem with IRT really is the variability and overall reliability of the test. There's a lot of variation that's related to climate and season that are related to lot-to-lot variation. So this is another one of your questions. Racial variation and variation related to perinatal factors. So this is something that was published from, Wisconsin, showing these here are, this is the mean IRT for all of their babies, and this is year to year from 1994 through 2003. The diamonds are the summer months, the 3 months of the summer, and the squares are the 3 months of winter. And basically what you can see, I'm sorry, so this is mean IRT, this is 95th percentile IRT. The message is basically the same. The assays basically give them a higher IRT in the winter than in the summer. Okay. So may have something to do with, again, temperature sensitivity of the assay, so on and so forth. And then this is a similar graph that just is documenting each dot represents a different lot that comes from PerkinElmer. It's the same manufacturer, but it's just a different lot. And you can see that there's a lot of bumps up and down. This is mean, and this is 95th percentile. So this is part of Phil Farrell's strong push towards getting percentile cutoffs for doing the IRT screen rather than fixed cutoffs. So I'm going to show you, we put together a poster for the CF meeting last fall that showed what was going on in Georgia, and I just have a couple of graphs that we showed that we had in that poster. So this is based on our experience from 2008 to 2011 in again over 500,000 infants. And this is just going to show you here between 2008 and 2011, month to month, 99, 98, 97, 96, 95th percentile. And so here again, just looking at that distribution over a period of time, you can see that if we, let's say if we're focused on 95th and 96th percentile, which is, again, keep in mind that we're using 55 right now as our cutoff, okay? But if we were using that percentile, you can see that there would be big differences from from 1 month to the next in general. Now the thing is though that pattern here in Georgia doesn't actually fit in with seasons. So this is, I put together this graph to be analogous to the one that Farrell and the Wisconsin people published, where they superimposed their winter and their summer values, and I did this with 95, 97, 98, 99 percentile. I just realized I didn't use the boxes and diamonds the way he did. I used dotted lines and undotted lines. But again, the point is, for example, here, if we look at 95th percentile, you can see that basically in the summer here it was higher in 2008, and it was around the same in 2009, and then 2010, 2011 it was lower. So we don't see that same seasonal pattern. we do see, and I think this is really the striking, and I'm going to show you something else about that in a minute, but I think the most striking thing that we see in Georgia, because of the fact that we've got a significant proportion of our population here is African American, it becomes important that the IRT, sorry, this isn't supposed to be RT, this is supposed to be IRT. The IRT measurements really are, oh, okay, and I apologize again, I didn't fix this slide. This is white or Caucasian versus African American. So the blue here is white, the red here is African American, and you can see that what we have is a distribution amongst the whites that has a pretty sharp peak here at 20 and a relatively narrow distribution compared to what you see in African Americans, where there's definitely a rightward skew to this distribution, and you start seeing a lot more African Americans who are above 55 or whatever our cutoff would be. So this becomes really pretty important here in Georgia. So basically, these here now are the, again, percentiles, 95, 96, 97, 98 percentile IRTs for the whole population during that time period. And so this is overall. This is winter, spring, summer, and fall, and this is not statistically different. This is greater than 2,500, 15 to 2,500, and less than 1,500. And you can see these less than 1,500 infants in particular have very elevated IRTs compared to the rest of the population. This is white, African American, Asian, and multiracial, and you can see the African Americans clearly peak up here. There's less of a difference that's not really statistically significant if you compare to the others. This is Hispanics versus non-Hispanics, and actually this is statistically significant as well, with Hispanics having actually a lower IRT. And then there's actually, this is not a huge difference in terms of number, but given the large population we have, this is a statistically significant difference between males and females. But I think the important thing here is birth weight, race, and ethnicity. These are all issues that are important and are going to be important determinants of sensitivity and specificity for our newborn screening. So let me just talk now a little bit about, again, the issue here about what is the cutoff and what does that do for you in terms of IRT. Basically, that's going to be your main determinant of sensitivity. So in Colorado, lowered their IRT cutoff from 105 to about 60, so or 90. Again, this is what they were using originally. Now 60 was right 97 percentile. Their sensitivity rose from 95 to 98.7. The Massachusetts people estimate that if they raised their current 95th percentile IRT cutoff to 98th, that the sensitivity would drop from 97 to 90. Okay. Again, this just reiterates this issue about the percentile. On the other hand, the changes in the mutation panel are probably, in general, don't make quite as much of a difference. Now, again, this is the Colorado estimates that you do make a big difference when you go from just screening for Delta F508 to just going to the ACMG23 panel. So you reduce your false negative rate from 8 to 9% to 2.3%. And then raising to the larger panel, at least for Colorado that they're using here, again, that does make a little bit of a dent, but it's not quite the magnitude of change that you get from changing your IRT. So let's talk about sweat testing a little bit now. So sweat testing is it's kind of this 20th century technology that we still have, but it's still really the gold standard. So we stimulate sweat in these babies using picarpine iotrophoresis. We don't just put them in a hot room. And the standardization of sweat is if they're sweating at a maximum rate. And so it's sort of an interesting thing. We talk about QNS, quantity non-sufficient, for sweat testing, and it's actually not because they're not generating enough sweat in order to do the assay. It's that that they didn't generate enough sweat to have reached that maximum sweat rate by which this sweat chloride is standardized. So anyway, it can be reliably performed after 72 hours of age. There's a lot of mythology about this, but the problem with the younger kids and the smaller kids is the higher likelihood of QNS testing. We did an analysis of the sweat test results at UNC Chapel Hill about 10 years ago, and basically found that infants who had a weight below 2,000 grams and infants who were African American had twice the QNS rate that the rest of the population has. So this is a challenge. Again, it's a challenge to us here in Georgia, and it also emphasizes the problem. And I didn't really get into this that much, but given the fact that the IRT in average tends to be higher in African Americans, we probably well, we do. We have a lower positive predictive value of the screening test in African Americans, and then we drag them up to Atlanta from wherever, Valdosta, and then they're more likely to be QNS and have to be dragged back again. So it's really it's a challenge. Anyway, sweat chlorides, the tradition that you see in all the textbooks for decades is that over 60 is abnormal, under 40 is normal, and 40 to 60 is indeterminate. In infants, it turns out that really down to 30 still is a possibility, and this makes it much more confusing, which I'm going to get into in a minute. But we clearly have kids who in the first month of life may have a sweat chloride of 30, who just end up having garden variety CF, not the variants that we're going to be talking about. But as we get down into the 30 to 40 range in particular, we also start picking up all of these kids who have these different sort of CF variants and CFTR-opathies that make our lives a little bit more complicated than we're going to be talking about here. But anyway, this is an important thing that we also need to make sure everybody understands, though, which is that when we do our sweat testing in the first 6 months of life, that down to 30 needs to be followed up on. So basically, the diagnostic screening process then begins with the positive screen, notifications of parents and primary care physician, and then a sweat chloride. If the sweat chloride is greater than 60, that's easy. If the sweat chloride is less than 29, that's easy. And when the sweat chloride is between 30 and 59 is when I start getting a headache. And it starts getting more complicated, because then it's sort of possible CF, or what we're going to talk about in a minute, the so-called CFTR-related metabolic syndrome. I'll just point out that what we've been trying to do here in Georgia, and this just makes sense to me, is that whereas everybody needs a sweat test if they have a positive screen, the babies who have 2 mutations, we are trying to get them just to be referred directly to a CF center and not have to get a sweat test first. So the CF center will follow up with a sweat test. But if they have 2 mutations, obviously we've got a situation that you need some CF expertise. The kids who just have 1 mutation, again, this is a very state-by-state dependent thing. Within Georgia, it's a center-by-center dependent thing. So that over at Medical College of Georgia, or the Georgia Health Sciences Center, the sweat testing is actually run by the CF program. And so when you send somebody for a sweat test, you really basically just send them to the CF center. Whereas here at Children's, when patients get sent for sweat testing, it has nothing to do with the CF centers. It's only, so it's just a lab function of the hospital, and so we don't get to hear about it until they have a positive sweat test, because we're not able to handle all the kids who just need a sweat test. Okay, So this in of itself could be a separate hour talk, and I decided that I already had too many slides in this talk anyway. So rather than show you all the evidence backing this up, I'm going to just ask you to take my word for it. CF newborn screening leads to better nutritional status, better cognitive function, which is sort of interesting, probably a nutritional issue. There's been some controversy, and I think I have another slide or two about pulmonary status, but really, I don't think there's any question in the long run we're going to show that it improves pulmonary status. Fewer hospitalizations, decreased risk of life-threatening complications and death in infancy, reduced treatment costs, and that's actually something that was documented in the UK, reduced parental distress, this so-called diagnostic odyssey of patients, of families who have kids where something's wrong and nobody's thinking about getting a sweat test. And then obviously the opportunities for genetic counseling for other siblings and future children. So let me just show you this just to tell you, because this is the benefit of newborn screening. This is a bunch of CT scans that were done because in Australia, where they've been doing newborn screening now for, again, at least 15 years, they've also set up a very aggressive protocol in which infants, when they're first diagnosed, and again, these babies at 1 month of age, you can't tell them apart from anybody. I mean, some of them are actually already beginning to show some drop off in their weight, but from a respiratory standpoint, they all look great. But the Australians are actually taking these kids diagnosed by newborn screening, and they're doing CT scans of the chest, bronchoscopies, infant PFTs in the first year of life. And what they're finding is that while these kids are born with normal lungs, it doesn't take long before that's no longer the case. And I'm not sure, this isn't really showing up very well, but when we do these CT scans, this is an inspiratory scan, deep breath in. This is an expiratory scan, deep breath out. And what you see, unfortunately, you can't see this. You're going to have to take my word for it. I don't know if you can make out, there's like a little hole over here. Okay. This you can only see what's been circled, but there's another little hole over here. There's over here. So the point is that we are finding bronchiectasis, which is the damage that leads to eventual respiratory failure in CF. We're seeing bronchiectasis in kids in the first year of life who look absolutely asymptomatic otherwise. And we're seeing it not in a huge number, maybe 8%. By the time they get to be 5 years, we're seeing them in 25%, or they are. And then this is the expiratory film, and again, unfortunately, you can't really see it very well. I don't know if you can see towards the back here. This looks a little bit whiter. This looks a little bit blacker here. This is maybe a little bit like that here versus over there. This sort of regional air trapping is basically the beginning of the CF problem. Remember we talked about the infection, inflammation, which causes swelling. That swelling causes obstruction. So when they're breathing out, some of these areas of their lungs aren't emptying the way the others are. And this is the way CF works. It works in a very patchy kind of way. It's not a diffuse sort of thing. So the first step towards getting this bronchiectasis is getting this sort of air trapping. And this is found in 75% of kids in the first year of life. Okay? So the point is that these kids look normal, but the process, this is like the Grand Canyon. This is how I talk to patients, right? It's like, the Grand Canyon started however many million years ago with this little river that was going down a flat little surface. And then over a long period of time, it just ate its way into this big Grand Canyon. And this is it. This is the beginning of that process. You don't see it. We don't see it, but this is the beginning of the process. So ultimately, newborn screening is now allowing us to intervene in these kids at this stage and hopefully, at the very least, slow the progression to that sort of the Swiss cheese lung that I showed you, earlier on. Oh yeah, so this is it. Oh, this is the numbers. So here, first year of life, 8.5% have bronchiectasis. 61.7% have air trapping. 38% have bronchial wall thickening. Again, by the time you get to, this is the 6th year of life. See, actually, it's a good thing I showed you this. The numbers I quoted you were completely wrong. So 43% of the kids at 6 have bronchiectasis. 57% with air trapping, 71% with bronchial wall thickening. So that first 5 years of life or so is really important to the beginning of this disease, and this is what newborn screening is giving us. This is just showing you, and again, you can't see it very well either, but this is the result of bronchoscopies done in infants in terms of looking for inflammatory cells and white blood cells. And this is in the CF population, a bunch of different studies reporting bronchoscopy results in young infants with CF. And you can see the neutrophil count or proportion ranges from 50 to 80%. The numbers are in the 100,000 range, as opposed to kids without cystic fibrosis, where neutrophils are maybe 5 to 9%, and the total numbers are an order of magnitude less. So again, this process of inflammation and infection is going on very early. So again, risks and benefits. So the benefits allow us to intervene in all that sort of stuff. And I'm just going to spend the next few minutes now talking about some of our risks and some of our headaches. So the biggest reason why we've had difficulty demonstrating an advantage in terms of pulmonary function from a CF newborn screening starts with the Wisconsin study. Because the Wisconsin study was two different CF programs, one of them in Milwaukee and one of them in Madison. The one, everybody knows this, so it doesn't matter if I name names. So the one in Madison had a separate day for kids who were diagnosed by newborn screening. And it doesn't, the day part of it doesn't matter. What's part of it, the point is that there were infection control measures that basically allowed the babies who were diagnosed by newborn screening not to catch the bugs that the rest of the CF population had. Whereas in Milwaukee, they were all sitting in the same waiting room. Okay? And so when you looked, so here, one center exposed infants to older infected patients in the first 6 years of life. Median age of colonization was Pseudomonas aeruginosa. At that center, it was 1 year of age, and then the kids who were not diagnosed by newborn screening, on average, didn't pick up Pseudomonas until 4.5 years of age. Okay. And again, I didn't talk about this, but Pseudomonas is a bacteria which is one of our bad guys in CF. It causes more worsening. The kids who were screened in Madison, their average age of acquisition of Pseudomonas was 5.6 years. So by the way, notice this, if you're not exposed to them, and there's data on this too, that newborn screening leads to a later acquisition of Pseudomonas than, but again, the point is here that because all these kids were picked up, they had, in Milwaukee, and picked up Pseudomonas earlier, and Pseudomonas makes your lung disease worse. Whatever potential advantage may have occurred was lost. So greater deterioration of chest x-rays with increasing age in the screen group. So again, going back to this MMWR recommendation, newborn screening for CF should be accompanied by rigorous infection control practices. And so again, this is one of the themes. You know, in order to do newborn screening, you got to make sure that you're doing that. So this is recommendations from the European conference. It's essential appropriate measures taken to reduce the transmission of Pseudomonas to screen babies. It doesn't have to be a separate day. Again, if you're doing the sort of recommended infection control measures, then you don't need a separate day. But you need to do that infection control. So what are some other implementation challenges? Lack of familiarity of PCPs. There's some people in the room who are very familiar with that. Lack of familiarity of PCPs with the process. Poor communication with families. Flawed notification of parents. Poor communication, lack of genetic counseling. The sweat testing problems that I've alluded to already. Difficulties in getting screen-positive babies to accredited labs. You know, they're 5 hours away. Can't they really get their sweat test in Savannah or in Albany or in, I don't know, whatever. And unfortunately, those hospitals are willing to do it. And then our problem here, this is actually a national problem. This is really underlying. It's not, I mean, we have problems with too many QNS sweat tests here at CHOA, but this is, again, it's been a big issue nationally. Unduly prolonged process to reach diagnosis and the diagnostic uncertainties that I'm going to squeeze in the last few minutes. Again, unintended effects, inconveniencing large numbers of families by requiring them to travel to Augusta or Atlanta, sweat testing, identification of carriers, and the so-called CFTR-related metabolic syndrome. Let me just show you, again, this is CHOA data here, just to give you an idea of our problem. The white line here, this is 2011. The white line here is the monthly QNS rate for sweat testing for patients over 3 months of age. Now, this is not quite as good as it should be. Overall, this is less than 5%. The CF Foundation wants us to be less than 5%. So overall, this is just barely tickling under 5%, and so, you know, we're acceptable as far as that goes, over 3 months. The blue line is under 3 months, and this is, again, from the CF Foundation standpoint, should be less than 10%. And overall, we're actually not too far off from that, but you can see that we have some really bad months here. And this has been a challenge, you know, here in Atlanta. Okay. So again, can I run over a few minutes? Is that okay?
Yeah.
Okay. So again, now I want to talk about these sort of CF variants, and specifically this entity that we're now calling CFTR-related metabolic syndrome, because this has really been a problem that we're trying to deal with. So normally, how do we diagnose CF? There are these consensus guidelines on the diagnosis of CF that say, well, here's what you got to have. You got to have one more characteristic phenotypic feature, you know, like respiratory, you know, significant respiratory symptoms, or maybe a history of CF in a sibling, or, well, okay, a positive newborn screening test. But of course, when they said that, nobody was doing newborn screening. So the point is that normally, or before newborn screening, actually, one of the requirements of the diagnosis of CF was typically, actually, that somebody presented with symptoms that made you think about CF. And then if you had somebody like that, then you would look for laboratory evidence of CFTR abnormality, like an elevated sweat chloride, or identification of 2 CFTR mutations, or maybe, again, this is, I don't know how much you guys know about nasal PD measurements, but it's a way of measuring CFTR physiology across the mucous membranes of the nose that is really more of a laboratory experimental kind of approach, but people have used it for diagnosis. But anyway, so again, the point is symptoms and a positive test, not just a positive test. And then, of course, back before these days, you know, it was a little bit more straightforward. If you look at the 2005 registry, only 3.5% of patients with diagnosis of CF had a sweat chloride less than 60, and only 1.2% had a concentration less than 40. So, you know, it made sweat testing reasonably good test. But now when we start bringing in babies in, so in Massachusetts, of those patients diagnosed by newborn screening, so Massachusetts has about 10-year experience, excuse me. So 8.2 of their babies diagnosed with CF had a sweat chloride of 30 to 59, and 2.7% had concentration less than 30. So we're already having difficulties here around our sweat test. And so, again, if we go back to situations outside of newborn screening, people have come up with a condition that used to be called atypical CF and different things, and now they've settled on CFTR-related disorder. The thing about CFTR-related disorder, again, is it begins with one or more characteristic phenotypic features. Now, this may not necessarily be significant respiratory issues or malabsorption. It might just be congenital bilateral absence of vas deferens, or sinus problems or whatever, but they still have some symptom that led them to be investigated. And then these are patients who then had sort of these intermediate sweat chlorides, at least over 6 months, and no or one CF causing mutation. So this was confusing enough. Okay, these are still tough patients. You still don't always know whether one of these patients is really going to really start looking more like they have CF or not. But the complicating issue now for us has been, oh yes, okay, sorry. So mutations, you guys, I'm talking to the choir here, I guess, but mutations in the CFTR gene can cause CF, but not all CFTR mutations cause disease. You have some that are clearly disease-causing. You have some that are associated with those CFTR-related disorders, like congenital bilateral absence of the vas deferens. You have some that are abnormal but have no known clinical consequences. And you have some that, people have found in one patient in the world, and so you don't know what they mean. I don't have time to go through this, but there's these functional classification. Are you all familiar with this? Or this functional classification, which is useful in thinking about CF, because there are different degrees of CFTR function that go along with these different sorts of classes. You've got some that never make it out of the cytoplasm, and they never make it up to the apical cell surface, and so they don't really have any function to speak of at all. And then you have others that make it up to the apical cell surface. They may not work very well in the job that they're supposed to do, but they're at least here, and so whatever little, so these tend to be patients with these classes of mutations who do have a little bit of CFTR function, and these are maybe, if they have CF, have pancreatic sufficient CF, or these may be some of our patients who've got these CFTR-related disorders. Because you can find some direct correlation between CFTR activity and clinical effects. So 100% you're okay, 50% you're a carrier, and you're pretty much unaffected, but you already have a slightly increased likelihood of recurrent pancreatitis and sinus disease. If you don't have any CFTR function, you clearly have garden variety CF. If you have a little bit of CFTR function, you'll have pancreatic sufficient CF, maybe going along with CVABD. And then there's these groups that have 5 to 10% or more, the so-called CFTR-related disorders, where again they may have bilateral absence of the vas deferens, with or without pancreatitis at least. So, so there's all this. So, and we can begin to classify these different mutations as Group A, CF causing, clearly documented. Group B, CFTR-related disorders causing a little bit of dysfunction. Group C, no known clinical consequences. But then, unfortunately, there's these situations that could be one, could be the other. It depends on what their background is. And so there are numbers that just sort of fall into, things just get grayer and grayer. And so now, here we are doing newborn screening. So now we have kids who have no symptoms, except for maybe, if you want to call an elevated IRT a symptom. Maybe it is. But they have no symptoms. They're just minding their own business, and somebody comes along and does gene testing on them. Mm-hmm. And lo and behold, they're finding abnormalities, but they don't necessarily have anything else. So CRMS is a new syndrome that people have just named. And specifically, that differs from this other CFTR-related disorder because these are specifically kids who've been uncovered through newborn screening. And if you and so again, it starts with the elevated IRT. Then they'll have a sweat chloride that's in the intermediate range. And again, we're not even necessarily talking about the first 6 months because what we're saying for all these kids, I'll show you an algorithm in a minute. But we're saying even by 6 months of age, they're sort of in this 40 to 60 intermediate range. And then they've got either no or one CF causing mutation. If they've got this intermediate sweat chloride, no or one CF causing mutation. Or maybe they've got a sweat chloride that's less than 40, and they've got 2 CFTR mutations. But they're not both obviously CF causing. So this is a big mess as a clinician, and it's hard enough trying to talk to my colleagues about it, let alone trying to tell parents what's going on here, because I don't know what's going on. These are healthy kids who happen to have a high IRT. They've got an intermediate sweat chloride, and maybe they have one CF mutation, or maybe they have a normal sweat chloride, and they've got 2 CF2 mutations, which probably don't do much. It's just kind of difficult. So we have a guideline of how, the CF Foundation has put together a guideline of what to do in terms of this diagnosis. And again, it starts with, hypertrypsinogemia with this intermediate sweat chloride, and basically the ones who on repeat have a normal sweat chloride are easy. The ones who get higher are easy. The ones who stay intermediate are the typical ones. So again, these are the kids who, we repeat at 6 months of age. And again, we have kids who maybe have a sweat chloride less than 60, and one group A and one group B or D mutation, or 2 in group B or D, or they have intermediate and 1 and 1, or kids who really just stay intermediate and have no mutations. And so what do we do with these kids? We're afraid to leave them, we're afraid to let them go because they may develop some manifestations of disease. But we don't want to make them feel like they're too sick. So, again, we're concerned that they're going to develop chronic sinusitis, pancreatitis, infertility, and maybe even some bronchiectasis. We know that a lot of these kids end up picking up Pseudomonas in their airway. We don't know what the significance of that is. But again, as CF doctors, it makes us unhappy when we find Pseudomonas in the airway. So the management here is to follow them intermittently by the CF center, maybe once or twice a year, but mainly by their primary care physicians. So the primary care physicians need to know about this. Genetic counseling for the family, good communication between the CF specialist and the primary care physician, where the PCP knows that if there's anything that starts looking even remotely like CF, they should call us. And then we like to see them once or twice a year so that we can do cultures. And just like the sweat testing, we're the only ones who can do reliable cultures. I'm not trying to make it like we're so special, but we do spend a lot of time. We have requirements from the CF Foundation as an accredited CF center that the microbiology lab uses special, very expensive techniques to increase the recovery rate of Pseudomonas on the cultures. And the typical lab outside of a CF center doesn't do that. I mean, in our lab, they don't do it for everybody. We have to mark down that this is a culture on a CF patient, and then they use these special techniques. Some special media, they keep them a little bit longer and so on. And so that's the best way to optimize your recovery of Pseudomonas. And then we are trying to eradicate it, which I won't get into right now, but we have an eradication protocol these days when patients first come up with Pseudomonas. And then basically we don't do anything else. We don't do any other lab testing or chest x-rays. We don't do our airway clearance therapy that everybody gets. The one thing we do tell them to do is no environmental tobacco smoke exposure and give the flu shot. I mean, tell that to everybody. So this is really the key. And communicating with the primary care physician. So in conclusion, CRMS presents a complex challenge to the family, CF specialist, and primary care physician. Care should be taken to avoid vulnerable child syndrome, because these kids really are probably fine. But some of them may become symptomatic, so we need to keep an eye on them. And we're hoping that with more experience with the CRMS, we can expect that we'll understand this a little bit better. These patients are being entered into the Cystic Fibrosis Foundation registry, so we will have the collective experience nationally of what goes on with them within, I don't know, 5, 10, 20 years. So in summary, early diagnosis and therapy through newborn screening has led to new opportunities for understanding of prevention, maintenance of health rather than treatment of illness, and prevention of all the badness that's associated with cystic fibrosis. And I apologize for running over, and I will stay for any questions that you might have.